So imagine walking into a hospital with a broken arm. You get an x-ray, the doctor slaps the film up on a light board, points to a jagged white line, and says, well, there is your problem.
Right. It's a very comforting, totally binary reality.
Exactly. The bone is either broken or it's not. But the moment you step out of the orthopedic ward and into the realm of neurobiology or psychiatry, that comforting x-ray machine just sort of shatters.
Oh, absolutely.
We are suddenly navigating this diagnostic landscape that is incredibly murky, where the lines between a cure, a crutch, and an actual cause of illness become dangerously blurred.
And honestly, nowhere is that blurrier than with the medications we take to alter our own consciousness.
Yeah.
I mean, when you look at the sheer volume of prescriptions written today for anxiety or insomnia,
It's staggering.
it really is. You realize we are basically conducting a massive population-level experiment on the human nervous system.
Yeah, and that scale is actually what drove us to look into this today for the deep dive. We're talking about benzodiazepines.
Right, the household names.
Yeah, drugs like Valium, Xanax, Klonopin, Ativan. I just assumed, like a lot of you listening probably do, that because these are sitting in millions of medicine cabinets right now, we must have them completely figured out.
You would think so, but it's a lot more complicated than that.
It really is. The stack of source material you brought in to explain this is terrifyingly dense. Looking at the renowned Ashton Manual, which seems to be the absolute Bible for this topic.
It definitely is the gold standard.
Along with that, we have comprehensive clinical papering guidelines from the Benzodiazepine Information Coalition.
Yeah, and I also pulled some deeply technical pharmacological papers, detailing the actual microscopic synaptic exchanges happening in the brain.
And some clinical reviews from scat pearls, too, right?
Yeah.
Just to ground us in how doctors are actually instructed to use these drugs.
Exactly. And when you put all this data together, the story of benzodiazepines, well, it stops being about a simple pill that just helps you sleep. It becomes a story about how aggressively the human brain adapts to its environment, often to its own profound detriment.
Which is wild. So our mission today, for everyone listening, is to map that out. We need to figure out what these drugs actually are, how they physically alter the molecular landscape of your mind, the legitimate medical fires they put out, and the absolute neurological marathon of long-term exposure and withdrawal.
It is quite the journey.
To frame this, I want you to picture your central nervous system as a high-performance sports car. Okay. Adrenaline and glutamate are your gas pedal. They rev the engine, they get you ready to fight or run.
Right, the excitatory system.
Yeah. Benzodiazepines, on the other hand, are the body's emergency brake system. And today we're looking at what happens when you pour an industrial chemical superfluid into those brake lines.
I like that analogy. And to really grasp the power of that chemical intervention, we have to rewind the clock a bit. We have to go back to 1955.
Okay, 1955.
Yeah, a chemist named Leo Sternbach is the one who actually discovered benzodiazepines, and they hit the medical market hard in the early 1960s.
Wait, what were people doing for severe anxiety before the 60s? Were doctors just, telling people to take a walk?
No, they were prescribing barbiturates.
Oh.
And barbiturates were incredibly effective at sedating people, but they possessed what we call a frighteningly narrow therapeutic window.
Meaning, the dose you take to get 8 hours of sleep is uncomfortably close to the dose that stops your heart.
It stops your breathing, specifically, yeah. Barbiturates cause profound respiratory depression.
Wow.
If you look at the cultural history of the 1950s and 60s, fatal barbiturate overdoses were incredibly common.
Like Marilyn Monroe, right?
Exactly. So when Sternbach discovered benzodiazepines, the medical establishment treated it like an absolute miracle. Here was a compound that could, calm a patient down, halt a panic attack, stop a seizure, but it came with a massive safety ceiling.
I really want to understand that safety ceiling, because we still hear all the time about people overdosing on things like Xanax.
Sure.
If it's a miracle drug that doesn't stop your breathing, why is it safer, chemically speaking?
Well, it all comes down to a neurotransmitter called GABA, gamma-aminobutyric acid.
Okay, GABA.
This is the brain's primary inhibitory neurotransmitter. It's the brake pedal in your sports car analogy.
Got it.
When you experience a spike in stress, your brain fires off excitatory signals to keep you alert. But if those signals just kept firing unchecked, your brain would essentially overheat in a state of permanent panic.
So to prevent that, your neurons release this GABA into the synapse, the microscopic gap between brain cells.
Exactly.
So the GABA floats across that gap
Yeah.
and hits a receptor on the next cell to calm it down. The papers call this the GABA-A receptor, and they describe it as this incredibly complex five-part structure.
Right, it's a pentameric structure. That means it is built from 5 distinct protein subunits, typically 2 alpha, 2 beta, and 1 gamma subunit.
Okay, 2 alpha, 2 beta, 1 gamma.
Yep. They arrange themselves in a circle to form a microscopic pore, basically a channel, in the wall of the brain cell.
Okay.
When natural GABA binds to the interface between the alpha and beta subunits, it acts like a physical key. It twists the proteins, opens that central pore, and allows a flood of negatively charged chloride ions to rush from outside the cell to the inside.
And because those chloride ions carry a negative charge, they literally cool the neuron down.
Exactly. They hyperpolarize it.
Right. They pull the cell's electrical charge so far into the negative that it becomes almost impossible for that neuron to fire off a pain signal or a panic signal.
That is the natural braking system in a healthy brain. Now, the common misconception here is that swallowing a Valium is just flooding your brain with synthetic GABA.
Which it isn't.
It isn't. Benzodiazepines do not open that chloride channel themselves. In pharmacology, we call them positive allosteric modulators.
I was trying to wrap my head around this allosteric modulator concept from the reading, and the best way I could visualize it is to imagine that this GABA receptor is a massive bouncer standing at the door of a nightclub.
Okay, let's see where you take this.
So GABA is the bouncer. His only job is to hold the heavy club door open to let these negative chloride ions inside to, like, chill out the rowdy party happening in the cell.
Right.
The benzodiazepine pill you just swallowed is not the bouncer.
Yeah.
And it's not some guy trying to pry the door open with his bare hands either.
I know, it's not.
The benzodiazepine is the bouncer's incredibly charismatic friend who stands next to him, whispering in his ear, convincing the bouncer to keep the door open far longer and much more frequently than he ever normally would.
That is a phenomenal way to visualize what we call the Monod-Wyman-Changé transition model, the MWC model.
Oh, good. I was hoping the analogy
It
tracked.
does perfectly. The benzodiazepine binds to its own dedicated site on the receptor, specifically wedged between the alpha and the gamma subunits.
So it doesn't even bind where GABA binds.
Nope. It doesn't necessarily change the receptor's affinity for GABA when the door is closed either, but the second natural GABA binds to the receptor. The benzodiazepine aggressively shifts the molecular equilibrium.
It locks the door open.
It physically locks the receptor into an open, high-affinity state. It makes your bouncer incredibly efficient at his job.
But the catch, and this must be the safety ceiling you mentioned earlier, is that the bouncer's friend is powerless if the bouncer goes home.
Exactly.
If there is no natural GABA present, the benzodiazepine can't open the door by itself.
That is exactly why they are safer than barbiturates. Benzodiazepines are incredibly weak, partial agonists on their own. The pharmacological data shows they have something like 1/27,000th the efficacy of natural GABA.
Wow, that's practically nothing.
Right. Without your body's natural GABA there to actually turn the key, the drug can't do much. Barbiturates, conversely, can force the door open all by themselves at high doses, completely independent of GABA.
Which is why they suppress the brainstem and cause lethal respiratory failure. Okay, so a pure benzodiazepine overdose might put you in a deep sleep for a few days, but it rarely kills you on its own.
Yeah.
Yet the medical news is full of fatal overdoses involving Xanax or Valium. What is breaking that safety ceiling?
Synergy. The fatal flaw is almost always polypharmacy mixing drugs.
Ah, okay.
If a patient combines a benzodiazepine with alcohol or with an opiate like fentanyl or oxycodone, they create a deadly synergistic loop.
How does that loop work?
Well, alcohol binds to different sites on those exact same GABA receptors, and opiates suppress the respiratory centers in the brainstem directly.
Oh, wow.
So you have the benzodiazepine convincing the bouncer to hold the door open, the alcohol physically forcing the door open even wider, and the opiate completely shutting down the body's autonomous drive to breathe.
That combination just completely annihilates the safety ceiling.
It does. It's a lethal triad.
That makes a lot of sense.
Yeah.
So we have this drug locking the brakes down, but the Stat Pearls review points out something really strange. We mentioned those 5 protein subunits that make up the receptor, the alphas, betas, and gammas. Apparently, the specific type of alpha subunit the drug hits completely changes human behavior.
It dictates the entire clinical profile of the medication. The brain has different flavors of these receptors. If a benzodiazepine binds to a GABA receptor that happens to contain an alpha-1 subunit, the resulting clinical effect is profound, heavy sedation, anterograde amnesia, and a triggering of the brain's reward pathway.
So alpha-1 is the switch that basically knocks you out and erases your memory of the evening.
Precisely. But if the drug binds to receptors utilizing alpha-2 and alpha-3 subunits, that is where the profound anti-anxiety effects and the muscle relaxation occur.
Okay, so the patient feels calm, their spine loosens up, but they might not feel overwhelmingly sleepy.
Exactly. And then the alpha-5 subunits are heavily involved in memory formation and cognitive modulation.
So which receptors do the household names hit? Like if I take a Valium or a Xanax, which alpha subunit is it targeting?
All of them.
Wait, all of them?
Yeah, traditional benzodiazepines are non-selective. They wash over the brain like a tidal wave and bind to alpha-1, 2, 3, and 5 indiscriminately.
Oh, wow.
This non-selectivity is exactly why taking a Valium relaxes a pulled-back muscle, stops a racing heartbeat, makes you drowsy, and makes you a bit forgetful all at the exact same time. It is a scattergun approach to the nervous system.
This actually explains a huge question I had about Z drugs. Things like Ambien or Lunesta.
Right, the non-benzodiazepine hypnotics.
Yeah, they're heavily marketed as sleep aids, and people always say, oh, I don't take benzos, I just take Ambien. But structurally, functionally, they are hitting this exact same GABA system, aren't they?
They are. Chemically, Z drugs are a different class, but pharmacologically, they are operating the exact same machinery. The difference is precision.
Okay.
If a traditional benzodiazepine is a scattergun, a Z drug is a guided therapeutic missile. They have been engineered to specifically target only the alpha-1 subunit.
The amnesia and sedation switch.
Yes. This perfectly explains why an Ambien will knock a patient out with incredible efficiency, but if that same patient tries to take an Ambien during the day to stop a panic attack or to relax a spasming shoulder muscle,
It won't work.
It won't work well at all. It selectively triggers the sleep pathways while almost completely ignoring the anxiety and muscle pathways.
Okay, let's pull back from the microscopic receptors and look at the whole human being. We understand how these drugs sweep into the brain, whisper to the bouncers, and flood the neurons with cooling chloride ions. How does this translate to clinical medicine? When an ER doctor reaches for these, what legitimate acute fires are they putting out?
Because they are such overwhelming neurobreaks, their legitimate therapeutic uses are life-saving. In the short term, they provide unparalleled rapid relief.
Right.
If a patient is brought in experiencing a severe, paralyzing panic attack, these drugs can stop it in minutes. They are used for severe, debilitating muscle spasms that don't respond to standard relaxants. And critically, they are the absolute frontline treatment for acute alcohol withdrawal.
Because alcohol withdrawal can actually kill you, right?
Yes. Untreated severe alcohol withdrawal can lead to delirium tremens and fatal seizures. The brain is so starved of the inhibitory effect of alcohol that it essentially electrically overloads.
So administering a benzodiazepine replaces the alcohol at the receptor and safely bridges the patient through detoxification.
Exactly. It's a critical intervention.
You mentioned seizures. The guidelines talk about status epilepticus. What is that?
That is a state of continuous, unyielding, life-threatening seizures. When a patient is in status epilepticus, their brain is caught in a devastating electrical storm. Intravenous benzodiazepines are often the very first line of defense to force that electrical storm to abort and save the patient's brain from hypoxic damage.
But the specific drug chosen for these different emergencies really matters. The literature spends a massive amount of time categorizing these drugs by their half-life. You know, how long it takes the body to eliminate half of the drug. I was surprised by how wildly different they are.
Oh, the pharmacokinetics dictate the treatment entirely. You have short-acting drugs like triazolam or midazolam, which hit hard and vanish quickly. You have intermediate-acting drugs like lorazepam, known as Ativan, or alprazolam, which is Xanax. And then you have the long-acting titans like diazepam, which is Valium, and chlordiazepoxide, known as Librium.
The potency differences are also staggering. The Ashton Manual highlights this because patients get really confused. If a doctor switches a patient from Valium to Xanax, it is not a one-to-one conversion. Half a milligram of Xanax is roughly equivalent to 10 milligrams of Valium.
It is a 20-fold difference in potency. This is a critical point of failure in patient education.
Yeah, I can see how that happens.
A patient might look at a tiny 2-milligram bar of Xanax and think, oh, it's just that's a tiny number. It's a small dose.
Right.
They don't realize they are ingesting the pharmacological equivalent of 40 milligrams of Valium, which is an incredibly heavy, profoundly sedating dose.
So how does an ER doctor navigate this menu? If someone comes in seizing, what are they reaching for versus someone coming in for alcohol detox?
For the seizing patient, the priority is rapid brain penetration. You need a drug that crosses the blood-brain barrier instantly.
Right, time is brain.
Exactly. A physician would likely use IV lorazepam or midazolam. They hit the central nervous system fast and hard to shut down the seizure. But if a patient is entering a rehabilitation facility for alcohol detoxification, a fast, hard hit that wears off quickly is the last thing you want.
You want something smoother.
You want a smooth, gentle, prolonged landing. So you would utilize a long-acting drug like diazepam.
And the reason diazepam gives that smooth landing is fascinating. It all comes down to the liver. The sources detail this split between phase 1 and phase 2 liver metabolism. I'll admit my eyes initially glazed over at the biochemistry, but the real-world implications of this, especially for older folks, are massive. Can you break down what the liver is actually doing here?
Sure, let's use an analogy. Imagine your body is trying to get rid of a piece of complex chemical garbage. Diazepam Valium goes through what we call phase I oxidation.
Okay.
It utilizes the cytochrome P450 enzymes in the liver to essentially burn the garbage.
But burning garbage creates smoke.
Exactly. As the liver breaks down the Valium, it inadvertently synthesizes entirely new active drugs called active metabolites.
So it's still drug.
Yes. It creates a metabolite called diazepam, which is also a powerful sedative. And that active metabolite can linger in the human bloodstream for up to 200 hours. It takes weeks for the effects of a single dose of Valium to fully clear the body.
Wow. But then you look at a drug like lorazepam Ativan, the papers say it skips phase I entirely.
Lorazepam and oxybepam bypass the burning process. They go straight to phase 2, which is direct glucuronidation.
Glucuronidation.
Right. Think of phase 2 as simply putting the garbage in a tightly sealed bag and throwing it in the river. The liver just tags the drug molecule with a sugar, making it water-soluble, and the kidneys excrete it in the urine.
So it doesn't create those long-lasting, lingering, active metabolites.
Correct. It's clean.
Why does a doctor care if the drug makes smoke or just gets bagged up? Aren't they both cleared eventually?
Because of the aging process. As humans age, or if a patient has liver cirrhosis from alcoholism, their phase I oxidative enzymes severely degrade. They lose the ability to burn the garbage efficiently. If you give an 80-year-old patient Valium for sleep, their liver cannot process it quickly. Those active metabolites from Monday's pill are still in their blood on Wednesday when they take another pill.
So the drug stacks?
The drug stacks. Day after day, dose after dose, the levels rise. Suddenly, that elderly patient is not just sleeping. They are severely oversedated, experiencing pseudodementia, and are at a massive risk for ataxia.
Ataxia, that's a loss of coordination, right?
Yes, and that leads to catastrophic falls and fractured hips. For elderly patients, standard medical protocol dictates you must use the phase 2 drugs, like lorazepam, because glucuronidation bagging the garbage is largely unaffected by age or failing livers.
That is terrifyingly easy to get wrong.
Yeah.
If you look at this list of benefits, halting seizures, stopping panic attacks, relaxing muscles, safely bringing alcoholics back from the brink, you might ask, well, why aren't we all taking these?
You might.
And yet, every single modern medical guideline explicitly states these should only be prescribed for 2 to 4 weeks maximum. If they're this miraculous, why are they relegated to short-term triage?
Because the brain is not a static organ, it is a homeostatic machine. The short-term miracle of a benzodiazepine inevitably, biologically, becomes a long-term liability.
What happened?
When the central nervous system is bathed in these drugs for months or years, the system fundamentally starts to break down and reorganize itself in a defensive posture.
What does that defensive posture look like for the patient? What happens to the person who takes a Klonopin every day for 5 years?
Clinically, we see a cascade of adverse effects. Chronic oversedation and chronic fatigue become baseline states. We see a phenomenon the Ashton Manual refers to as emotional anesthesia, which is a profound emotional blunting.
Just feeling numb.
Exactly.
Uh-huh.
We also see increased rates of clinical depression and bizarrely paradoxical stimulant effects.
Wait, paradoxical. How does a chemical brake pedal cause someone to rev up?
It's very similar to the mechanism of alcohol. Because the drug strongly inhibits the brain's impulse control and behavioral regulation pathways, patients sometimes lose their filter.
Okay.
They experience sudden bouts of rage, aggressive outbursts, severe irritability, or terrifying nightmares. The drug meant to calm them strips away their ability to regulate their anger.
Let's talk about that emotional anesthesia for a moment,
Yeah.
because the patient anecdotes in the literature are heartbreaking. People write about bitterly regretting their lack of emotional response to their own children's lives while on these medications.
It's very common.
When I read that, it felt like someone wearing high-end noise-canceling headphones 24/7.
How do you mean?
Well, if you put on heavy noise-canceling headphones, they do a brilliant job of blocking out the painful, deafening noise of a panic attack or severe workplace anxiety.
Mm-hmm.
They protect you from the bad, but because you never take them off, they also muffle the quiet, beautiful sounds of joy, connection, empathy, and love. You don't feel the panic, but you also don't really feel the hug from your spouse. You are emotionally insulated from your own life.
That is precisely the clinical presentation. They feel fundamentally disconnected. And alongside that emotional numbing, the data shows measurable, significant cognitive decline.
Like memory loss.
Yes. Long-term users demonstrate marked impairments in visuospatial skills, their ability to sustain divided attention, and their working memory. It physically becomes harder for them to process new information or hold complex multi-step thoughts in their mind.
This brings us to one of the most hotly debated, frightening topics in the deep dive: the link between chronic benzodiazepine use and Alzheimer's disease or dementia. Some of the epidemiological studies show a really clear, scary connection.
They do. Multiple large-scale observational studies over the last decade have shown that chronic use is statistically associated with a significantly increased risk of developing dementia later in life. The risk ratio climbs noticeably with higher cumulative doses and with the use of long-acting drugs like diazepam.
But the STAT Pearls review threw a flag on the play here. They brought up the classic causality versus correlation problem. They aren't convinced the pill is literally melting the brain.
Right. It is the ultimate chicken and egg problem in medical research, we have to ask. Is the benzodiazepine physically causing the dementia? Or are severe, intractable insomnia and sudden severe anxiety actually early, prodromal signs of a brain that is already in the early stages of developing Alzheimer's?
Well, I see. So a 65-year-old goes to the doctor because they suddenly can't sleep and feel terrified all the time.
Uh.
The doctor prescribes a benzo to treat those symptoms. 5 years later, the patient is diagnosed with Alzheimer's.
Exactly.
The drug didn't cause the dementia. The drug was just prescribed to treat the very first warning signs of the dementia.
We call that protopathic bias. We don't have definitive proof that benzodiazepines are directly neurotoxic in a way that causes structural dementia. However, what is universally agreed upon is that whether the drug causes it or not, benzodiazepines unequivocally worsen cognitive decline and confusion in patients who are already developing dementia.
The Ashton Manual spends a lot of time addressing patient fears about brain damage. A lot of long-term users are terrified their brains are physically shrinking. But CT scans of chronic benzo users don't show the kind of brain atrophy you see in a chronic alcoholic, right? Where the cerebral cortex literally shrivels up.
No, they don't. You don't see dead patches of neurons or structural voids. The emerging consensus is that the damage is functional, not structural.
Like a computer where the hardware is perfectly fine, but a virus has completely rewritten the operating system.
That is a highly accurate way to frame it. The settings of the brain have been altered at a genetic and molecular level. The literature points to changes in gene expression, altered receptor density, and shifts in regional blood flow.
So the hardware is intact.
But the software running the nervous system has been corrupted, and that corruption persists long after the actual chemical is cleared from the blood.
To understand how that software gets corrupted, we really have to look at how the brain fights back against the drug. We have to look at the neurobiology of tolerance, dependence, and addiction, because they aren't the same thing, are they?
They are completely distinct phenomena. Tolerance is the brain's initial defense mechanism. Because the brain seeks homeostasis, a balanced state, it recognizes that the brake pedal is being pressed too hard, too often by this drug. So it starts to dismantle its own brake system to compensate.
The sources point out that your body builds tolerance to different effects at totally different speeds.
Yes. Tolerance to the hypnotic effects, the sleep-inducing properties, happens incredibly fast. Often within a matter of weeks, your deep sleep patterns return to their baseline dysfunction, and the pill simply stops knocking you out.
And the anti-anxiety effects.
Tolerance to the anti-anxiety effects takes longer, usually a few months, but it inevitably occurs.
And when that tolerance hits, patients experience a horrifying phenomenon called interdose withdrawal, meaning the original symptoms The panic, the insomnia start bleeding back into their day, sometimes worse than before, even while they are still taking their prescribed daily dose.
Right. Their brain has downregulated its natural calming system so aggressively that the daily pill is merely keeping them at baseline. Between doses, as the blood level drops even slightly, they plunge into a severe GABA deficit.
Let's separate dependence from addiction for a moment.
Huh.
Physical dependence makes sense. The brain adapts to the chemical. But addiction involves craving, compulsive, drug-seeking behavior. How does a drug that acts as a brake pedal trigger the brain's reward center? I thought things like cocaine and amphetamines caused addiction by flooding the brain with dopamine. How does Valium do it?
It is a brilliant, highly counterintuitive mechanism mapped out in the pharmacological papers from Frontiers. Benzodiazepines absolutely trigger the brain's reward center, the pathway from the ventral tegmental area, the VTA, to the nucleus accumbens. But they don't do it by directly stimulating dopamine production. They do it through a process called disinhibition.
Disinhibition, so they are inhibiting the inhibitors.
Exactly. Picture the ventral tegmental area. You have your dopamine-producing neurons, which want to fire and make you feel good, but right next to them, you have local GABA interneurons. These interneurons act like local police officers.
Keeping the peace.
Their entire job is to keep a tight lid on those dopamine neurons, making sure they don't fire wildly and cause erratic behavior.
So what happens when the Valium hits that police station?
The Valium selectively binds to the alpha-1 receptors on those specific local GABA interneurons and intensely inhibits them. It essentially arrests the police officer.
Oh, wow.
Without the local police to enforce order, the dopamine neurons are free to fire wildly, flooding the nucleus accumbens with dopamine. This massive dopamine release tells the brain, whatever you just ingested, do it again, reinforcing compulsive drug-seeking behavior.
It's a double negative that creates a profoundly positive reward. And this isn't just a fleeting chemical wash either. The research shows this triggers actual physical synaptic plasticity.
Yes, it rewires things.
The sources state that just one single dose of diazepam alters the ratio of AMPA to NMDA receptors in the VTA for up to 3 days. It is physically rewiring the circuitry of the reward center after a single use.
It is aggressively reshaping the brain. But the truly terrifying mechanics of physical dependence happen directly at the GABA receptor itself. When the brain decides it can no longer tolerate this artificial sedation, it executes a highly coordinated, multi-step microscopic rebellion to shut those receptors down.
I want to walk through this microscopic rebellion step by step because it completely blew my mind. If the brain feels it is drowning in benzos, what is its first move? What is step one?
Step one is uncoupling. The brain essentially severs the communication line. The physical receptor is still sitting there on the cell wall, but the specific site where the benzodiazepine binds structurally stops communicating with the site where natural GABA binds.
Going back to our analogy, the bouncer's charismatic friend is still standing there whispering in his ear, but the bouncer has suddenly gone completely deaf.
Exactly. The drug loses its ability to potentiate the GABA. The brain is attempting to ignore the drug.
But patients often just up their dose when that happens, right? They take more pills.
Right.
The floodwaters keep rising. What is step two when ignoring it fails?
If the flood of medication continues, the brain resorts to physical removal. This is a process called endocytosis.
Endocytosis.
A specific enzyme called RNF34 approaches the GABA receptor and chemically tags it for destruction. This tagging process is known as ubiquitination.
So it slaps a condemnation sticker on the receptor.
Precisely. Once tagged, the cell membrane physically folds inward, creating a pocket. It sucks the receptor inside the cell, forming a vesicle, and delivers it to the lysosomes. Lysosomes are essentially the cell's internal garbage crushers or acid baths. They dissolve the receptor entirely.
So the brain is literally eating its own calming receptors just to escape the medication.
But the brain doesn't stop there. Because those receptors don't just float freely, they are securely anchored in place at the synapse by a complex structural scaffolding protein called gefferin.
Gefferin.
Yes. Diazepam causes that gefferin scaffolding to be phosphorylated specifically at a molecular site called serine 270.
I remember this detail.
Mm-hmm.
Phosphorylating the gefferin basically makes the scaffolding brittle.
Yes. It alters the structure so that an enzyme called calpain can come in and cleave the gefferin apart. It actively smashes the foundation.
Wow.
Without the gefferin anchor holding things together, any remaining GABA receptors literally detach and float away from the synapse, rendering them completely useless for fast signal transmission.
Okay, let me try to synthesize this for everyone listening, because the scale of this destruction is hard to grasp. Imagine your brain is a coastal city facing a massive, endless chemical flood of benzodiazepines. At first, the city tries to just ignore the rising floodwaters. That is the uncoupling. But the waters keep rising, the patient keeps taking pills. So the city government decides extreme measures are required to survive.
Right.
It literally unbolts the city's storm drains. Those are the GABA receptors.
Mhm.
It slaps a condemnation sticker on them. That's the RNF34 ubiquitination, and throws them into the city incinerators, the lysosomes. And just to be absolutely certain no new drains can be installed, it brings in jackhammers and pulverizes the concrete foundations, the Gefrin holding everything in place.
That is dark.
But accurate, right? Your
Yeah.
brain physically deletes its own calming infrastructure, tearing up the streets, just to reach a new baseline against the drug.
That is a highly vivid yet scientifically accurate translation of what is happening at the synaptic level. The brain adapts by making itself physically, mechanically incapable of relaxing normally.
Which brings us to the terrifying cliff edge of this story. If your brain has physically demolished its own calming infrastructure, the storm drains are gone and the foundations are smashed to dust, what happens on the day those pills run out? What happens if you try to go cold turkey and the floodwaters instantly vanish?
You are left in a state of profound, catastrophic neurochemical crisis.
Let's talk about the perils of rapid withdrawal. What is physically happening in a brain that stops cold turkey?
By abruptly removing the benzodiazepine, you leave the brain with a massive, glaring deficit of GABA activity. The brakes are completely gone. Simultaneously, the brain's excitatory system, primarily driven by glutamate, which has been trying to fight the drug all these years, is suddenly running completely unchecked.
So it's a state of extreme neurological hyperexcitability.
Exactly.
The gas pedal is glued to the floor, the engine is redlining, and the emergency brake lines have been cut. What does that actually feel like for the patient experiencing it?
Patients frequently describe it as a waking nightmare because GABA is responsible for modulating sensory input. Without it, patients experience agonizing sensory hypersensitivity. Normal room light physically hurts their eyes. The hum of a refrigerator sounds like an airplane engine. They experience severe, piercing tinnitus or ringing in the ears.
The clinical sources list some incredibly bizarre neurological symptoms, too. They talk about jelly legs and something called formication. What is that?
Formication is a terrifying tactile hallucination. It is the distinct, undeniable sensation of insects crawling on or burrowing just underneath the skin.
Why does a lack of GABA make you feel bugs?
Because of sensory gating failure. Right now, you are wearing a shirt. The fabric is touching your skin. Your peripheral nervous system feels it, sends the signal to your brain, and your brain's GABA system filters it out, saying, that's just a shirt, ignore it.
Right.
Without GABA, that filter is gone. The gentle friction of your clothing or a slight breeze on your arm is misinterpreted by the hyperexcitable brain as tiny legs moving across your skin. The brain cannot categorize the input correctly.
That is horrifying. The sources also mention profound depersonalization, feeling completely detached from reality, and severe gastrointestinal distress.
The brain-gut axis goes into overdrive because there is a massive concentration of GABA receptors in the digestive tract. Patients experience severe nausea, agonizing cramping, and relentless diarrhea. But as distressing as these symptoms are, the real danger lies in the severe medical complications of abrupt withdrawal.
We are talking about grand mal seizures.
Exactly. Without GABA to dampen and isolate electrical activity, a normal misfire in one part of the brain can rapidly cascade and spark a seizure that spreads across the entire cerebral cortex. We also see acute, terrifying psychosis and delirium tremens-like states involving profound confusion and hallucinations.
And these can be fatal, right?
These complications can be and periodically are fatal if they are not medically managed in an intensive care setting.
Which is exactly why the Benzodiazepine Information Coalition and the Ashton Manual are so aggressively, militantly opposed to rapid tapers. And yet, patients consistently report encountering prescribers who recommend tapering methods that seem medically catastrophic.
Unfortunately, yes.
The sources highlight two specific practices that doctors sometimes suggest that are highly dangerous. The first is the 25% a week reduction.
Yes. A well-meaning doctor might say, just take a quarter less of your pill each week and you'll be safely off in a month. For a brain that has fundamentally restructured its synapses, demolished its receptors, and smashed its Gefrin scaffolding, 4 weeks is nowhere near enough time to rebuild that infrastructure. Dropping a dose by 25% all at once plunges the patient straight back into that glutamate storm.
And the second method, which seems almost universally condemned in the literature, is skipping doses. The doctor says take a pill Monday, skip Tuesday, take one Wednesday. Why is that uniquely torturous?
It comes back to our earlier discussion on pharmacokinetics and half-lives. If you are taking a short-acting drug like Xanax or Ativan, it clears from your bloodstream relatively quickly.
Okay.
If you take it Monday, skip Tuesday, and take it Wednesday, you are strapping your central nervous system onto a violent chemical roller coaster. Monday, your brain is sedated. Tuesday, your blood levels crash and you are in acute withdrawal. Wednesday, the drug floods back in and slams the brakes on again.
You are throwing the nervous system into a state of violently fluctuating neuroshock.
Precisely. And the clinical data strongly suggests that these kinds of shock and awe, fluctuating tapers, heavily increase the risk of the patient developing protracted withdrawal syndrome, or PAWS.
Pause and delirious. This is the phenomenon where the withdrawal symptoms don't just last for a few weeks, but persist for months, or even agonizing years after the very last pill is taken.
Because the brain was shocked so severely by the rapid chemical fluctuations, the genes governing receptor expression and the neuroinflammatory pathways get stuck in a dysregulated, damaged state. True neurological recovery becomes an agonizingly slow process.
One specific symptom of this withdrawal that really jumped out at me is the muscle tension rebound. We mentioned earlier that these drugs are potent muscle relaxants. So when you remove them, I imagine the muscles essentially snap back like a stretched rubber band.
They do. Patients experience intense, unyielding rebound tension. This manifests as severe tension headaches, which they often describe as feeling like a tightened steel band wrapped around their skull.
Oh, that sounds awful.
They suffer from severe jaw pain and cracked teeth because they are unconsciously violently clenching their jaws at night, and they experience profound spine stiffness that makes simply getting out of bed an ordeal.
There is also an incredibly specific, yet highly common, medical danger I want to highlight from the sources. The fluoroquinolone danger. This is something I feel every single person taking a benzodiazepine needs to know, because it sounds like a hidden landmine.
Yes, this is a critical drug interaction that is tragically overlooked. Fluoroquinolones are a widely used class of broad-spectrum antibiotics. The most famous one is probably ciprofloxacin, or Cipro.
Used for common things, right?
Yeah.
UTIs, sinus infections, pneumonia.
Right. The danger lies in the fact that fluoroquinolones act as competitive antagonists at the exact same GABA-A receptor sites that benzodiazepines utilize.
Competitive antagonist. Break that down for me.
It means the antibiotic actually physically displaces the benzodiazepine. It sweeps into the synapse, chemically knocks the Valium or Xanax right off the receptor, and takes its place.
Oh, wait, really?
Yes. But critically, it provides absolutely no calming effect of its own. So if a person is physically dependent on a benzodiazepine and they take a pill of Cipro for UTI, that antibiotic can instantly, within hours, plunge them into acute, severe withdrawal, regardless of whether they took their normal benzo dose that day.
That is terrifying.
Mhm.
Just taking an antibiotic for a sinus infection could throw you into a grand mal seizure if your brain is dependent on benzos.
It can trigger immediate delirium, profound panic, or seizures. It chemically blocks the benzo from working.
Okay, I want to push back on something here. I'm sure listeners are thinking the exact same thing. We hear these horror stories of people taking years to taper, suffering unimaginable agony, shaving pills with jeweler's scales.
Yeah.
But we also all know someone, a neighbor, an uncle, who took Klonopin every day for a month after a nasty divorce, stopped taking it, and was totally fine.
Sure, we all do.
Why the massive discrepancy? If the drug is this destructive, why can some people just walk away while others face years of torture?
It is a vital question, and it speaks to the immense variability of human biology. First, we have to reiterate that physical dependence happens to almost everyone over time, but the severity of the withdrawal syndrome is highly individual. Genetics play a massive, unpredictable role here.
Genetics regarding what? How fast the brain destroys the receptors.
Exactly. We all have genetic variations in how aggressively our brains manage receptor downregulation. We have variations in how efficiently our liver enzymes clear the active metabolites. And most importantly, we have variations in our natural neuroplasticity, how quickly our brains can pour new concrete and rebuild those pathways once the drug is gone.
So some brains are just better at remodeling themselves.
Yes.
Yeah.
Additionally, baseline psychological factors matter immensely. A patient's underlying anxiety disorder, their individual stress coping strategies, their socioeconomic stability, their social support network, these all profoundly influence whether the withdrawal experience is merely uncomfortable or entirely debilitating. It is highly unpredictable, which is why clinical caution and slow tapering are universally recommended.
So given everything we've talked about, the destroyed receptors, the glutamate storms, the danger of skipping doses, the genetic roulette, how do you actually get out? If a listener or their loved one is trapped in this chemical maze, how do they safely navigate their way to the exit without destroying their life in the process? What is the gold standard?
The universally recognized gold standard is a gradual, patient-led tapering protocol, heavily guided by the principles laid out in the Ashton Manual. The operative phrase there is patient-led.
Okay.
The speed of the taper must be dictated entirely by the patient's symptoms, not by a rigid, arbitrary calendar on a doctor's desk. If the symptoms become intolerable, you hold the dose until the brain stabilizes.
And step one in the Ashton protocol is often a crossover, which sounds counterintuitive. Why would a doctor take someone who is physically addicted to Xanax and prescribe them Valium? Aren't you just trading one addiction for another?
It goes directly back to our discussion on liver metabolism and pharmacokinetics. Short-acting drugs like Xanax or Ativan cause that interdose withdrawal. The patient is constantly yo-yoing up and down, feeling sick between doses. Step one is often carefully switching the patient from the short-acting drug to an equivalent therapeutic dose of a long-acting drug, almost always diazepam or Valium.
Because Valium has those phase-I-active metabolites that linger in the blood for 200 hours?
Precisely. By substituting Valium, you create a pharmacokinetic buffer. The blood serum levels remain incredibly stable and flat throughout the entire day and night. The yo-yoing completely stops. The brain is no longer being shocked. Once the patient is stabilized and comfortable on the Valium, you then begin the process of slowly lowering that dose.
And by slowly, we mean micro-tapering. Step two is micro-tapering. We are not talking about snapping a pill in half and hoping for the best.
Absolutely not. Breaking pharmaceutical pills yields wildly uneven, unpredictable doses. The active ingredient is almost never perfectly distributed throughout the inert filler in a tablet. For a severely sensitized nervous system, dropping the dose by a half or even a quarter of a milligram might be enough to trigger severe, debilitating symptoms.
So how are patients actually achieving these microcuts? The ingenuity here, driven by sheer desperation, is kind of amazing to read about.
Out of pure necessity, patients and specialized tapering doctors have developed incredibly precise methodologies. One is dry tapering, where patients purchase highly sensitive digital jeweler's scales to literally shave microscopic amounts of dust off their pills using a metal file, weighing the pill every single day to drop the dose by microgram.
People are literally filing their pills like prisoners filing bars on a cell.
It is a meticulous, exhausting process. In some countries, pharmacies offer specialized tapering strips, which are blister packs pre-dosed by a compounding pharmacy to lower the dose by infinitesimal exact amounts each day.
And the Benzodiazepine Information Coalition guidelines also detail liquid titration. How does that work?
Liquid titration involves dissolving the solid pill into a liquid suspension vehicle. Some use prescribed medical suspensions like Aura Plus, while others simply use high-fat whole milk because the fat helps suspend the lipophilic drug evenly.
Oh, clever.
Once the drug is perfectly suspended in the liquid, they use precision oral syringes to pull out a tiny exact fraction of a milliliter more each day. This allows for a completely smooth, linear descent, giving the brain the required time to synthesize new GABA receptors and rebuild that Gefrin scaffolding as the drug slowly, gently leaves the system.
Now, what about other drugs, adjuvant medications? If the withdrawal is this physiologically agonizing, can't a doctor just prescribe something else to smooth it over? An antidepressant, a beta blocker, or something?
Generally speaking, adding more psychotropic drugs to an already severely destabilized central nervous system is strongly discouraged by the top experts in the field. There is very little clinical evidence that introducing antidepressants or beta blockers actually speeds up the neurological healing process, and they often carry their own side effects that confuse the clinical picture.
So just wait it out.
Usually, yes. However, if a patient is forced into a rapid detox, say, they are in an inpatient rehab facility that aggressively cuts them off in 7 days. Doctors will heavily utilize anticonvulsants like Devolprox or sodium valproate.
Not to make them feel better or reduce the anxiety, but simply to keep them alive.
Exactly. The anticonvulsant is administered purely to prevent a catastrophic grand mal seizure during the acute shock of rapid withdrawal. But it does absolutely nothing to stop the panic, the sensory overload, the insomnia, or the physical pain.
There is also a massive psychological hurdle here that the experts point out, and it's something I hadn't really considered. The chemical taper, shaving the pills, that is only half the battle.
It is. Think deeply about someone who has been on these medications for 10, 20, or 30 years. Every single time they felt acute stress, profound grief, intense anxiety, or blinding anger over the last 2 decades, the pill handled it for them. The pill blanketed the emotion before it could be processed.
I never had to take the noise-canceling headphones off.
Right. As a direct result, many long-term users never developed normal adult stress coping mechanisms. Their emotional processing has been chemically frozen in time.
Wow.
So, as the drug slowly leaves their system, not only are they dealing with the physical torture of sensory hypersensitivity, but they are suddenly feeling raw, unfiltered, overwhelming human emotion for the very first time in decades. And they are doing it without the psychological tools required to process it.
That sounds overwhelming.
It is.
Mhm.
True healing requires intensive behavioral therapy, like cognitive behavioral therapy, to run concurrently alongside the chemical taper. They literally have to relearn how to feel, how to grieve, and how to cope again.
That is profound. It's not just a physical detox. It is an emotional rebirth, and a highly painful one at that. Let me throw one more scenario at you, because this is a massive recurring fear I saw plastered all over the patient support forums and in the literature.
Okay, what is it?
What if an ex-user, someone who spent 2 agonizing years micro-tapering off Valium, finally gets clean, but then gets into a severe car accident? They go to the hospital, they need emergency surgery, and the anesthesiologist hooks them up to an IV and gives them midazolam, a powerful, short-acting benzodiazepine for the surgical anesthesia. Will that single dose instantly undo years of healing and physically re-addict them?
It is a terrifying prospect for ex-users, but the Ashton Manual is very clear and very reassuring on this exact point. A single medical dose given for a surgical procedure will not physically re-addict them. The physical changes to the receptors, the ubiquitination, the structural breakdown take time and sustained, repeated exposure to develop.
So their brain won't instantly uncouple the receptors and smash the gefferin just from one IV drip.
No. The physiological addiction will not return from one isolated dose. However, the fear of that dose, the intense psychological anxiety of knowing the drug is back in their body, might trigger a severe cascading panic attack that mimics their old withdrawal symptoms. The danger in that scenario is almost entirely psychological, not physiological.
That is a crucial distinction. The hardware is fixed, but the software still vividly remembers the trauma. Okay, let's zoom out and try to bring this massive topic together. We are reaching the end of our deep dive. The journey into and out of benzodiazepine dependence is undeniably daunting. But the overarching theme of all these sources, the message that underscores every terrifying molecular change we've discussed, is the incredible concept of neuroplasticity.
Right.
Brain's relentless ability to physically reshape itself to adapt to the drug is what causes the horrific dependence. But that exact same mechanism, that plasticity, is the very reason full lasting recovery is possible. The brain can rebuild the storm drains. It can pour new concrete.
It absolutely can. It just requires immense time, extreme patience, and the slow, methodical removal of the toxic stimulus.
Let me summarize the critical takeaways for you, the listener, from this massive stack of research. Benzodiazepines, Valium, Xanax, Ativan are incredibly powerful molecular tools. They act as positive allosteric modulators, supercharging the brain's natural braking system, GABA, to provide rapid, unmatched short-term relief for panic, life-threatening seizures, and severe muscle spasms.
But that immense power comes with a severe, unavoidable cost over time. Chronic use forces the brain into a defensive posture. It actively dismantles its own calming infrastructure through uncoupling and endocytosis, leading to tolerance, profound emotional blunting, measurable cognitive decline, and deep physical dependence.
And because of that massive physical restructuring, exiting this medication cannot be rushed. Abrupt withdrawal or skipping doses plunges the brain into a dangerous, potentially lethal state of excitotoxicity. The only scientifically sound, humane way out is a slow, mathematically precise, patient-led taper, often utilizing a long-acting buffer like Valium and microtapering down to the microgram.
It is a long journey of reclaiming the nervous system.
Now, before we sign off, our expert found one final, lingering mystery to leave you with. A thought from the very bleeding edge of neuroscience that was buried deep in the pharmacological papers.
Yeah, we spent this entire deep dive talking about how the brain reacts to a synthetic chemical, Valium, invented in a lab in 1955. But from a purely biological standpoint, this raises a fundamental evolutionary question. Why do human brains possess highly specific, perfectly shaped benzodiazepine receptors in the first place?
Right. Evolution didn't meticulously build these highly complex molecular docking stations just sitting around waiting millions of years for Leo Sternbach to synthesize a pill in a test tube.
Exactly. In biology, if a receptor exists, it exists for a reason. It exists because the body produces a natural endogenous substance that is meant to bind to it. Think about opioid receptors. We possess them because our bodies produce natural endorphins to kill pain. We possess cannabinoid receptors because our bodies produce natural endocannabinoids. So, what is the brain's natural Valium?
The sources mentioned that scientists are actually finding the answer to that right now.
They are. They are currently isolating small polypeptides in human and animal tissues that they have named endozapines.
Benzodiazepines.
Yes. These are the body's own natural, built-in, internally produced benzodiazepines. They bind to that exact same allosteric site to naturally modulate GABA and soothe the nervous system during times of extreme stress.
So the ultimate question for the future of psychiatric medicine isn't just how to get people safely off these synthetic pills. The real frontier is figuring out how to safely, naturally unlock and boost the brain's own endozapine system. How do we teach the brain to soothe itself using the tools evolution already installed?
It changes the entire paradigm. It shifts us from indiscriminately introducing a foreign destructive chemical to optimizing and supporting our internal neurochemistry.
It really does. It brings us all the way back to that X-ray machine we talked about at the very beginning, the muddy waters of neurobiology. We're looking at a system so complex, so intricately balanced, that pouring our synthetic superfluid into the brake lines causes catastrophic microscopic chaos. But the more we clear the mud, the more we understand the receptors, the subunits, and the endozapines, the more we see the incredible, resilient design underneath it all. Thank you so much for joining us on this incredibly complex, fascinating journey. We hope this deep dive gave you some real insight into the mechanics of your own mind. Keep asking questions, respect your neurobiology, and stay fiercely curious until the next deep dive.